Well, and thank you for organizing this conference, which to my knowledge is the first one in the world on use of wireless technology in schools. I don't know of any other conferences about this, although I know that there are lots of concerned, mainly parents, around the world on this issue. And I will split my time a little with Tarmo Koppel from Tallinn University in Estonia. He will talk about exposure levels and so on. We have actually been involved in this area for quite a long time, since almost 2 decades, I would say. And I'm by profession a medical doctor, an oncologist, cancer doctor. And I would also say, according to what Darius nicely told about, for example, ICNIRP, that medical doctors are virtually absent in all these committees evaluating cancer risks and other risks. So that's really a problem when one decides what are the real risks with this technology or not. I will present the risk for brain tumors, mainly glioma, which is, well, there are different types of gliomas, but it includes the most malignant type, which has a survival of 6 to 12 months, very short survival. And I will use the Bradford Hill viewpoints, which were established in 1965. This was on the story of smoking and lung cancer risk. The evidence was there for almost decades before the decision came in 1960s that this is really carcinogenic. And Sir Bradford Hill in UK, he gave 9 viewpoints that should be more or less fulfilled to classify an agent as a carcinogenic substance. First, as you can see from this slide, the use of wireless technology is almost saturated around the world. You can see the expansion of the mobile phone technology and also the internet access going up very quickly from 2007. And as you know, this is rather new exposure looking into man's history, and also this is problematic when you discuss the health risk of Wi-Fi, because we don't have the decades of necessary latency period, time from exposure until the potential outcome. What we can study now are basically acute effects, headaches, cognitive defects, sleep problems, etc., which are described. And the very few students and teachers who really become electrosensitive and have difficulties to go to school. But the long-term health effects like cancer, if existing, they will take decades. So if we expose the children at this time, we will find or see the result in when they are 40, 50 years old or even more, as Doris said. And this will be problematic, of course, because it will be on an individual basis difficult to trace an exposure which is so far back in time. That's always a problem with epidemiology, to decide what the cause and effect is, because regarding cancer is usually very long time periods. Well, the first item in the Hill criteria was strength. Is there a consistent, or is there a result showing an increased risk in different studies? And we can see, for example, the Interphone study, the IAC study, which showed those with more than 30 minutes per day for 10 years had a 40% increased risk. The risk is 1.4. No risk is 1.0. So this means significantly increased risk, and also showing that this is significant because the lower border of the confidence interval is exceeding 1.0. We have a follow-up study, or another study rather, from France in 2 years ago, which showed almost 3 times increased risk, and then our study, which is a doubled increased risk. This is very sensitive. And if you make a meta-analysis of these studies, you combine them, you come up with about doubled increased risk for those who have used the mobile phone at least 1 hour per day for 10 years. These numbers are based on, results are based on rather high numbers. You can see here that there are 445 exposed cases. Your case, CA says for case, those who have the brain tumor, and controls are the persons from the population who don't have the tumor but are there for comparison. And this is based on almost 500 cases and 500 controls. So it's a rather large number in epidemiological viewpoint. There is also a consistency between the different studies, which always the previous slide show. When you look at to the right side here, you have those who have used the mobile phone for 10 plus years. And then you have the different studies, and the risk, which you can see here, is a doubled risk, and in the different studies. And all of these different studies show about 1.5 to 2 times increased risk. So the finding is consistent in different settings. And this is a rule because you usually say that a single study doesn't be enough to show an increased risk. You need to have studies in different populations by different study groups, etc. And here it's as I can see, a consistent result. The next issue is this risk specific for brain tumors in different areas. And as you can see from this picture, it is the exposure level. You can see the yellow point is where you hold your mobile phone and the distribution of the radiation into the head. And this is for an adult person up to the left. Then it's a 10-year-old one and a 5-year-old one. And as you can see, the young person has higher exposure to the brain. This is problematic because they are also, the developing brain is more sensitive to radiation. So there is a biological effect also which worsens this. The reason that the exposure is higher to the child, more volume of the brain is irradiated, is that the skin is thinner, there is absorption in the skin of the radiation, the bone is thinner, it's about 30% absorbed by the bone, and the head is smaller. So in a smaller head, it will penetrate deeper than in a larger head as in adults. And you can see from this study the distribution of the radiation, which is called SAR, specific absorption rate. And these are different parts of the brain. In the right side, that's the side where you held the mobile phone. You can see that for the 900 GSM, 96% goes to that side, and for 1800 megahertz is 99%. And most goes to what we call the temporal area of the brain. The brain is divided in different sections, different parts anatomically. Frontal, which is in the front, occipital, which is up here, and the temporal, which is around the ear. And you can see here that half of the radiation goes to the area surrounding the ear. So then the risk would be highest in that part. And it's actually, if you look into exposure, people had always to tell in these studies what side of the ear side of the head they used the mobile phone, left or side, or both sides, and to what extent, either right or left side. And then the tumor was localized depending on the brain scans, CT, computer scan, or magnetic resonance image. So we could decide in all these studies where is the tumor located. And you can see here that in these different studies, Interphone, Corot, and in our study, the risk is highest in the area where the highest absorption of the radiation is. Of course, there are some who have used both sides, which will dilute the effect, something that Doris talked about, the diluting effect in different studies. What we did in our study was that we included all types of brain tumors. Down to the left you can see the glioma, which is in the red part, glioma brain tumor, which is usually very malignant, and it's not very well circumscribed, so it grows out like fingers into the brain, which is problematic when you do the surgery, because you will usually not be able to take off the whole tumor. It doesn't metastasize, so it doesn't go to the lung or liver or whatsoever, so it's only in the brain. And then there is the meningioma, and that's a brain tumor which is located on the meninges, which is the part that is covering the brain. So it's a very superficial tumor. What we did is that we actually looked into the glioma patients and the meningioma patients, and we used the meningioma patients as, so to say, a comparison group instead in this calculation, instead of the control persons from the population. And ipsilateral means that sorry, this is very sensitive. Ipsilateral means that the tumor is on the same side of the brain as you have used the mobile phone. Contralateral is that the tumor is on the other side. And if you can see here, on the contralateral side, there is no significantly increased risk. To the right side here, from mobile phones or cordless phones. They are very little discussed, the cordless phones or the DECT phones, which are basically a type of mobile phone and give the same type of radiation. And people are really usually unaware about that. And also the base station for the cordless phone, it emits radiation all the time. So never you had it close to your bed, for example. But anyhow, the summary of this is that when we use the meningioma patients as, so to say, a control population to the glioma patients, we find still an increased risk for glioma. And this is done so that we can say that these results are not depending that you have a cancer. You say, okay, I have a cancer, so I was exposed here and so. But you can see that here are two cancer groups, and the risk goes only for the gliomas and not for the meningiomas. And this can also be shown in this slide, where 1.0 is no increased risk, and the table goes up to 5.0, which is fivefold increased risk, and 0.5 is reduced risk, 50%. And you can see that the dark line in the middle, it goes like 1.0 all the way, no increased risk. These dotted lines are the so-called confidence intervals. Instead, if you go to the glioma cases, you can see quite a different pattern. You can see that the risk increases with time, and the real steep increase comes after 15, 20 years. You can see on the dark line that it goes after, in these studies, for 20 years. Since use, the risk is 3 times increased. So this is what we call latency, time from first use of the mobile phone until the tumor develops. And we have careful data on that. People had to tell when they first started to use their mobile phone, and also, of course, to what extent they use it, how many minutes per day, and also what year they had used. So these results are, of course, problematic, and also one reason why we don't see so much in cancer incidence, because it takes decades until we can see the effect when we look into the numbers of cases. And this is also problematic as to children, because they are on the left side of this curve, and still the risk is increasing over the years. So there is actually, which I'm not going to talk much about, a rather small study on childhood brain tumors, which came up with an increased risk, significantly increased risk based on operator data. They asked the mobile phone providers about their use of that specific mobile phone. So there's actually an increased risk among children, but it's a very small study. Temporality means that, as I told, or you saw in the previous slide, that the risk would increase over time. And Mostly the results are for 10 years, as Darius told us. You have the Interphone study, the Corot, and our studies, and all go with an increased risk after 10 years from first use of the mobile phone. Our study group is the only one that has 20-year data, and is the two lines below that, and the risk is highest in that group. After 20 years, it's more than doubled increased risk. There should also be a biological gradient. The more you talk, the higher the risk. And we can see here that those who talk 1,000 hours cumulative, if you add the minutes per day over the years, and here it's up to some 10,000 hours over the total life, and they have the highest risk. And this is what you would expect if there is a cancer-causing agent, that the risk increases with how much you use, how much you are exposed. I mean, a person who smokes 2 packages of cigarettes per day has a higher risk of lung cancer than a person who just smokes 5 cigarettes a day. So you can exactly see here that the more you use the mobile phone, the higher the risk. It's problematic also, as Darius indicated, that the use in these studies, which are old, it reflects the use back in the 1990s and early 2000s and so on. And we have no smartphones in these studies because they were not invented at that time. But the other problem is, of course, that the time for use of mobile phone has increased so substantially now. The people talk a very long time per day in a mobile phone as compared with this old data. It was very expensive at that time also. Well, there should also be some experiments that can indicate an increased risk, and these are the Henry Lai studies from USA. We can see in the middle a brain cell and what they say a sham exposed rat. I mean, the brain is not exposed to mobile radiation, to radio frequency radiation. And then you compare it with the next, where you can see that there is what we call the DNA fragmentation. So it's not directly the DNA is hurt in other way than that there are fragments of it, the Comet assay technique. And this is nicely shown actually by Henry Lai and some other study groups, and it's rather low exposure, 0.6 watt per kilogram for 45 minutes, short time exposure. Also, I don't know, you will perhaps cover the NTP study, so I won't go so much into it, but the recently released results from NTP study show similar results, that you can get an effect on DNA by exposure. What about the incidence? You would like to see that the numbers of brain tumors go up if there is a causing agent, like for lung cancer went up after smoking. And what we can see here in the Swedish data, using the inpatient register for those who are in hospitals for a brain tumor until 2015, you can see that there is a rather steep increase from 2007. It's about 4% increase per year, which is a significant increase per year of brain tumors diagnosis in the inpatient register in Sweden. These are recently released data. And if you divide this in different age groups, you can see to the left side the percentage of the increase up to 4.5% per year, and a different age group up to 90 years, there's an increase of which is 1.5. It's not significant, but the highest increase is in the group of 20 to 39 years. And if you look into these different age groups, and it's more than 2%, 2.5% increase per year of patients with a brain tumor in the Swedish inpatient register. And this is of course varying, because this is the group where if they use a mobile phone during adolescence and you have a lag time of 10 or 20 years, they will come into this group and get the brain tumor. So that's exactly what we are finding now, that could be an early indication that the young persons, the children, are at an increased risk. Still, these are low numbers, as Darius said, because brain tumor overall is a rather rare tumor, but we have also released data on thyroid cancer, which is exploding now in incidence in the Western world, and the smartphones give rather high exposure to the thyroid gland, which is down here. So if you look into the age group of 20 to 39 years, you can see that these data from 1998 up to 2015, that there is a straight line of increase over the time. If you look overall, this is the blue line is use of mobile phones, and the red line is death in brain cancer using the death register. And you can see that there is, after some years, there is almost a parallel increase of deaths in brain cancer, and most of these would be the malignant gliomas, which have a very short survival of 6 to 12 months in regular. So if there's a causative effect, you would expect that after a latency period of, in this case, about 6-7 years, you find an increase in the numbers of patients that die in brain cancer. There are also UK data that are being published, and they show the red line that there is actually an increase of the glioblastoma tumors being the most malignant brain cancer over the years. So these data are quite clear that there is an incidence increase. We have also looked into the risk to die of if you have used a mobile phone, and I think I go to this one. And you can see that those who used the mobile phone before the age of 20 years, the top line of age for first use, and we can look into all wireless phones to the right side, and you can see that they have the highest risk to have a shorter survival when they have got the disease. So it's not only that the risk seems to be higher in that age group, and we have looked into that, but they have also a shorter survival. So they die quicker, those who have used the mobile phone before they got the tumor. I mean, not everybody who gets the tumor has been using the mobile phone, of course. So we have compared the two groups, those who used the mobile phone and those who did not. And we see that those who have used the mobile phone, they have a shorter survival than those who haven't used it. So it gives an indication that there is a biological effect of the radiation. So it doesn't only increase the risk, but it gives a worse type of worse prognosis of the glioblastoma. There are also experiments. This was a study where they had radio frequency exposure, and they looked into the reactive oxygen species, ROS, and this is the main mechanism. It's thought now that the reactive oxygen species, which are created by different exposures actually to the body, they will hurt the DNA, the base pairs. You can see the DNA at the bottom and the base pairs, and they will damage the base pairs. And this is blocked by, by alpha tocopherol, that's E vitamin. And as you can see in this experiment, it was really a little said when it's published that, okay, use your mobile phone, but take the E vitamin pill, so it will not damage it. But this is an experiment that really shows that there is a toxic effect on DNA by radiofrequency radiation. Pathology findings is that the NTP study in USA, they found among those who were exposed to mobile phones, mobile phone radiation had an increased number of gliomas. I mean, also glial hyperplasia, which is a precursor to a glioma. But they found in this study exactly the same types of tumors as had been found in epidemiology. And this is a very convincing result, and that's the reason that they wanted to present these results before they are even published. There's also a similar finding of schwannomas, which is a special type of tumor. They found it in the heart, and it's actually in different studies shown to be an increased risk of the schwannoma, or a tumor on the hearing nerve in the brain or from the ear. This is a high exposed area when you use the mobile phone against your ear. So again, here are results from epidemiology and from animal studies that are similar. In summary, there is an increased risk for glioma and acoustic nevrinoma, but not for meningioma so far. It can be so that it comes after a longer latency period. And this is very consistent finding in different studies. The highest risk is for tumor, which is on the same side of the brain that you have used the mobile phone, ipsilateral exposure. Highest risk is for those who had used the mobile phone before 20 years of age. And this, of course, is in accordance with, as I said, that the brain is more sensitive in young persons to radiofrequency radiation as well as to other agents. And the other problem is, of course, that they have a much longer time to have an adverse health effect from radiofrequency radiation because they start in a very young age compared to us that are older to this technology. And also a decreased survival for cases with glioblastoma. So conclusion according to these Hill criteria would even be that this causes brain cancer. And the next question is, of course, if you have a situation that you have a cancer-causing agent, what should you do? Is it free to expose the population to this or not? I mean, if we take asbestos, you wouldn't dream to build a school with asbestos because you know that it kills lung cancer. You wouldn't dream to say to the teacher or the children, it's okay for you to smoke to the lessons, because there are no studies on school situation and if the teacher is smoking. So we have to use, and the risk for cancer, so we have to use analogy. What's found in the literature of adverse health effects, and from that we must take conclusions, and I would concur with Darius that we need to use the precautionary principle and not expose the children, because there is the wired solution, and it's, I mean, there are, as I think, two problems. One is screen time, but the other one is radio frequency radiation, and you can principally avoid the radio frequency, and it will not give any problems to give a proper education of the students. Of course, it will maybe cost a little more to have wired connections everywhere in the schools, but maybe that's a cost benefit, so we have back the money in the future by fewer persons that are get the disease. And getting a brain tumor is almost one of the worst tumors to get, because the prognosis is so bad, and these children and these grown-ups who get a brain tumor, they have a very poor lifetime until they die. The time is shortened. So there will actually be a book that will be published March 28, which will partly deal these aspects on what Darius mentioned, the corporate interests. Who is deciding our future? Is it the corporations, or is it the democratic principle, or is it the scientific community overseas that decides this? And this technology is running far ahead of science, and is driven by industry and by governments and by agencies, and the warnings are not heard. And many countries the media is quite silent about this issue. So the Reykjavik appeal was pronounced by a small group of us on wireless technology in schools, because Svein wanted to have some kind of statement after this conference, and it's very difficult to make a statement in short time, so we were a few persons that wrote this one-page appeal. And it has gained quite a lot of interest over the whole world, and about 120 persons who have signed it by now, and it has been already translated to Spanish, to France, and parent groups have asked, can we use it at home in our schools, etc. So it's not an isolated problem. There are many advocacy groups around the world who are working with this and who want to stop the wireless technology in schools. So if you can do it, then it would be a marker for the whole world if Iceland can do something. Okay, thank you. I hope there is some time for Tarmo to talk now, and we can take questions afterwards. And there will be a discussion too, of course.